So welcome back everybody to the monthly AVH webinar, support webinars. Thanks so much for coming tonight. We are going to be discussing assessing the vitality, the vital force of your patients and how that plays into how we prescribe for and manage these cases. Subil is going to be talking to us primarily to begin with. So let's get going right now. Let me see if I can unmute. Actually, it doesn't let me unmute everyone. I can mute everyone. So if you have a question, just put it in the question box, raise your hand, and I'll unmute you. Or if you'd like, Sue, I can unmute everybody one by one.
Yeah, however that works is fine. I think there'll be some opportunity for some interaction.
All right, so Art's unmuted. Sounds quiet. Cindy is unmuted. Henry
For
is
guys who are
unmuted.
multicasting, unmuting could be not good.
Yeah, and you should be able to mute yourselves actually. Jane, let's welcome Jane, Robin, and Sarah. And it does sound like your noise is a little higher now.
Yeah, it does a little bit.
Yep.
Let's just work with it and see what happens.
Okay. Shoot.
Okay, it's great. It's great to have you guys all gathered up here this evening. One of the things that we've found over time, and it's kind of been reminding me lately, just with some discussions that I've been having with some colleagues about some cases and some of the stuff that I've been reading on the forums and that sort of thing, is that whole question about how do we assess the vitality of the individuals presented to us for care. And kind of in my worst moments in the last couple of weeks, I think it's like you play spin the bottle and you kind of make a wild guess. And so one of the things that we thought that we would talk about is just how do we do that? And it's one of those things that may sort of seem simple after you've done it for a while, and oftentimes we're not really good at articulating why is it and how is it that we make those assessments. And again, this really got fueled from some discussion that we had on the Pitcairn Institute mentoring group, and is actually an essay that I told that group that I would write for them at some point. I stuck this cat in here as a shot at the beginning, just because it's such a cool photograph. It's a photograph from a colleague of ours, and this photograph was taken just a couple of hours before the cat died. And it was so cool because that kind of misty stuff that you see coming out the ears was captured on the film, and was actually the client and my colleague saw it in the examining room. And when we think about where the kidney chi is and that sort of stuff, I just think it's a very mystical, magical photograph. So one of the things that we find is it's imperative to actually accurately assess the vitality of the individuals. It's one of those sort of fundamental, foundational things that we do as homeopaths. But as I said earlier, we don't tend to be really articulate about how we do that and that sort of thing. So we can gather here sort of as our collective group. I'm going to share some ideas and some of the ways that I look at things, and I'm certainly happy to have any and all of you guys contribute to things that you've found that have been meaningful to you in your clinical experience when you actually make that assessment of the vitality. I think it's really good that we actually stop and do that, that we actually sort of ritualize the doing of that in the same way that some of the things that we do in our history taking and that sort of stuff as well. So some of the things that I find and have found over the years is that people get tricked by things, and so they presume that for instance, age has got something to do with vitality, and so a lot of times we'll see cases get written up or get presented that say, oh, he's a young dog, so he's vital, and because of this we're going to do this or this or this or manage this or this or this. We get tricked into thinking that all levels of activity are correlated with vitality, both either positively or negatively. Oh, he's been on a raw food diet and his parents were on a real food diet, and that means he's sometimes they say that means he's healthy. Sometimes they say, that means he's got a high vitality. He hasn't been vaccinated, or he's from a vaccine-free kennel or group of animals, and therefore they're more vital. Or that they've had, a history of having had natural care and therapeutic intervention, and that in and of themselves will make individuals more vital. And it's my experience and my opinion that comes out of that experience that in and of themselves those things don't necessarily mean that an individual is more vital. And so as we'll talk this evening, we see a lot of young animals that really are scraping the bottom of the barrel, or most of the toothpaste is out of their tube. We see individuals certainly where the use of real food and species appropriate diets may not be using up their remaining vitality. It could be feeding and nurturing and allowing them to express stuff more appropriately, but at some level you're not going to raise tons and tons and tons of vitality solely on a real food diet. What we do often see happening is that the individuals become better nourished and sometimes better able to express symptoms. And yes, that does add to the vitality, but it's not going to be very often that we're going to cure a case just through the use of food. And we see a lot of, I say that now because I'm going to loop back and talk about that, because oftentimes that response to diet or changes in diet or errors in diet is something that we can use as a yardstick to talk about, how relatively vital or not vital they are. We also see that with vaccines, and we'll circle back to that. We can certainly erode vitality. We can certainly activate latent or not so latent chronic disease. We can certainly get vaccine disease grafted onto the pre-existing chronic disease as well. Vaccines in and of themselves do not necessarily mean that the animal is more vital, less vital, more sick, less sick. So we often get a lot of judgment that, oh, they've been vaccinated, therefore this is a bad thing. And I think we need to really put that whole business into context and recognize that relatively vital, relatively healthier, relatively more dynamic individuals will be able to tolerate exposure to vaccine or exposure to suboptimal food choices without turning things upside down. The other thing that we have this crazy fallacy about, I've found over the years, is that any individual experiencing natural care or natural therapeutic intervention is, I'm flapping my fingers in the air, better than individuals that are receiving conventional medicines. And so some people will say that, any and all conventional medicine is suppressive. I would debate that. Sometimes it's nicely palliative, it's rarely curative. I would also really encourage us to recognize that we can really palliate, suppress, non-curatively manipulate, whatever those words are that we want to use, individuals using natural care and natural therapeutics. And so I think we need to not be blinded to that. The assessment of the vitality is going to influence a lot of things. These things run both ways. So the understanding and assessment of the disease process is going to allow you to assess the vitality. And the same token, assessing the vitality is going to give you a more full understanding and assessment of the disease process. when we look at where is that individual on that relative continuum of vibrantly healthy to dead, when we look at where have they put their symptoms, I always talk about that three-dimensional view that we get of symptoms. Where is it in the body anatomically? Where is it in that continuum of, is it a sensation, is it a functional symptom, is it a mild pathology symptom, is it a deeper pathology symptom, is it fixed in the meat, is it an exterior symptom, skin, eyes, ears, is it a relatively interior symptom on the gastrointestinal tract for all the way from the mouth to the anal orifices, is it a relatively more interior symptom on those one end opened organ systems that we've had, like the respiratory system and the genitourinary system, or is it deeper and deeper and deeper into the meat, as I often say? So we get that two-dimensional view, and then we can round that out with linear time. You know, what's happened over a period of time. So has that individual been really good at keeping symptoms at a functional level? Has that individual been really good at keeping symptoms at a surface level, you know, in the skin, or does that get moved around? We'll talk a little bit about that as this conversation unfolds. The assessment of the vitality also is going to help us with that big question, you know, what medicine do we choose, be, and what needs to be cured? You know, where is actually the seat of the disease? What organ systems are there? Is the fact that the individual hasn't ever made any real symptoms necessarily mean that that individual is healthier than an individual who has made symptoms? And that's an error that I see a lot of times. You know, folks are quite surprised that why would a perfectly healthy, vital animal all of a sudden get sick with a big, scary label diagnosis, you know, without any prodromal or any history, and this just happened, you know, out of the blue. And a lot of times it may present out of the blue, but it didn't just happen out of the blue. You know, we talk a lot about individuals who are actually too sick to make symptoms, or you know, too sick to actually get a coherent response. When we talk about vitality, you know, we talk about the P's that I love, you know, the whole business of prognosis. You know, we can talk about things. We can never talk about what an individual is going to do, because we've never treated that individual before, but we can make some assessments based on other individuals that we've treated over time about, you know, how levels of vitality tend to respond. We can talk about that expectation of response, the pattern of response, the pace of the response. Are these the individuals that we're going to have to kind of seduce to come out and play? Are they individuals with a vibrant system that is ready, you know, just waiting, you know, it's waited the whole life for that, to see that particular remedy and that particular potency? Or is it an individual that doesn't really have any congruence or coherence in their ability to make a response, and so that they might be overreactive to your homeopathic medicine in the same way that they might be overreactive to other medicines and drugs? The other time that we'll see is that they're sort of just like a quivering blob of jelly on the floor that can't even make a reaction. So those things are going to influence the pattern and the pace of the responses, and those in turn are going to be part of the consideration that we make when we start talking about posology. And how do we deliver the remedy? In what form do we deliver the remedy? The potency of it, how you know, the method of dosing, those sorts of things. If you guys haven't listened to some of the nice presentations that Gregory Pace has provided for this webinar series, it would be really great to go back in the archives and talk a little or listen to those things as well. So we get that whole thing about response and expectation of response, and that's going to influence how we handle the remedy, and it's also going to influence how we handle our expectations as clinicians, and it's also going to influence how we handle our timing of our follow-ups with our clients as we're, trying to get the best, most accurate information that we can get, and also, helping those individuals be brave, oftentimes in the face of a new modality or a new experience with medicine, and often in the face of some interesting, scary clinical symptoms. And so it's a big pattern of stuff that we're talking about when we start looking about assessing vitality. We also know that we need to look at that. It's, a multi-dimensional approach, and that's what we're going to talk about next, is all of those different axes of observation and stuff that we kind of put into the soup and distill down to make a number or a high, medium, or a low kind of assessment. The thing that we also find is because via the response of the individual and the honing of our clinical skills, we can continue to determine if our initial assessment was accurate. Did we land that sort of more or less in relationship with reality? And the other thing that you'll also see, that as we have curative, appropriate response to therapeutic intervention, to dynamic therapeutic intervention, we're going to start to see that there gets to be more vitality in the bucket. Henrietta made a really great point at a meeting that we were having. A group of us were together discussing some cases and some approach to cases, and she was talking about how, and if I've misphrased you, Henrietta, jump in and whop me upside the head and make this correct. But basically, she was reminding us that bodies only had so much energy, that they have to eat and sleep and digest food and wander around and do their bodily function things and heal and repair and all of those sorts of things. Make symptoms, respond to symptoms, respond to errors in diet and supplement and non-curative manipulations. And if the energy is spread really thin, the body's not going to be able to do that as well. Or if it's using its precious energy trying to deal with crappy food or deal with raw food when really it needs warm cooked food or something like that, it's not going to have as much energy to be able to be able to respond to healing. So we start. I'm going to start with the individual's history, and I did that purposefully. I thought about starting from the parental history and the quote genetics, but I think we need to start with whom we're presented. And so a lot of times people talk about vitality based on diagnostic label. So the presumption is artificially incorrectly made that, oh, it's just got skin symptoms and so it's got to be more vital. We forget about, or it's got some scary label diagnosis that has us thinking it's less vital, and we forget to look at the multidimensional. What kind of symptom? Where is it? How good has the individual been over the period of time, putting that symptom in that place and keeping it in there? Where did the symptom start? Where is the first sign that first articulation of the naturally occurring disease? Where does that occur? So if we have an animal, for example, the case that I was working with a colleague with earlier this week, where the animal is 3 months old and doesn't have its testicles where it belongs, we know that animal has got some perhaps functional but relatively deep-seated disease, because we've got early symptoms, and they're structural. Things aren't where they are. Teeth are missing, for example. Things that are supposed to be there aren't there. Those sorts of things. We look also at what has been the prior articulation of the symptoms. So not not what is the disease. As homeopaths, we think about what is the disease. So the prior articulation of symptoms would be that sort of master problem list, those multiple diagnostic labels that they've had. And and what have those been, and how has that individual responded to treatment? So ironically, the things that we get all proud about as conventional clinicians and we don't often think about as homeopaths is an animal that has this diagnosis, has a skin symptom, and has a little bit of magic bath or something, and then has an ear symptom, and we put 2 drops of something in, or 3 days worth of a 10-day prescription, and that's cured, so they don't have to give it anymore. And then we cure a bladder infection with 1 course of antibiotics, and then there's some arthritis stuff, but it's okay, we're treating that naturally with some supplement thing. um, those animals that are switching symptoms around like that and moving fairly quickly from superficial functional symptoms to deep symptoms, and that are really easily manipulated by our therapeutic intervention, those animals are not very vital. And that can be just a really, really easy, quick assessment to make. Um, the other thing that we'll see is loss of modalities too. The 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 less vital ones, the diagnostic label is cured by the manipulation, and then we move on to another diagnostic label. The more vital they are, that they may want to keep the symptom in the same place, but they'll start to slowly lose modalities and clarity. So that relative response to treatment, whether they're easily manipulated or whether they've got a certain stubbornness and by George, I want to put that symptom there, that gives us a good sense of the vitality. And then the question, looks about, do they have a coherent, cohesive response to the disease, to the therapeutic intervention, to their environment? Um, how relatively resilient and stable are those individuals? Have they been able to create symptoms appropriately through their lives, or do we have a case where we have a one-sided case? And those one-sided cases, true one-sided cases, in my opinion, are oftentimes not particularly vital individuals, because they end up getting themselves into a world of woe without ever having had articulation of any other signs of disturbances. Sometimes we see one-sided cases that are one-sided because we're crappy case takers, and that's probably a conversation for another webinar before this season wraps up. But true one-sided cases, if we have that, that should have bells going off in your head that maybe this individual is not as vital as you think that they are. I threw this in there. This is a really nice case that we worked on a couple of years ago, actually, with fowl pox in a group of animals that the farmer actually ended up making a no-sode out of it. It's a really super case, but I threw it in there because it's a nice turkey picture. So one of the other things that we need to look at is the family history. And this really was driven home to me. Couple weeks ago, I was working with a colleague, and we had a case, and the individual was I forget how old, couple-year-old dog, who parental generation, probably 6 or 7 years actually, and the parental generation, both parents had died of brain tumors, and one of the parents had a bunch of other tumors before it actually had a brain tumor. And we were having a discussion about how we expected this animal to respond to care, and what kind of symptoms was it showing, and what kind of prognostic pace were we expecting and stuff. And the thing that got really, really clear pretty quickly in the conversation was that the clinician with whom I was having the conversation didn't really fully have their head wrapped around the deep, deep, deep level of chronic disease that these animals came into in the world. forget the non-curative manipulations for 6 years and that sort of stuff that had happened. But the fact that this is this is an animal that was born of two animals that died of brain tumors, and the bitch had some really interesting reproductive issues and didn't want to get bred and had a great difficulty maintaining pregnancies, and oh, by the way, wanted to eat her babies and those sorts of things. And so we have an expectation then, knowing that even though the upholstery on those dogs was pretty nice and that they were functioning pretty nice, these are deeply, deeply sick animals. This is different. This inheritance of the level of health of the parental generation, this is different than genetic inheritance. This is energetic inheritance, and we need to really understand that. And this is the thing that I think is really exciting as we work as homeopaths, because we can actually change that level of health of the parental generation. So I think when we have cases, it behooves us to know about the parents to some extent. Were they on thyroid medication? Did they have difficulty conceiving? Did they have, some marvelously non-curative manipulated disease? I would rather have an animal that was bred from somebody that was, responding to homeopathic care, dynamic intervention care, that might have some symptoms, rather than somebody who had been, quote, cured or managed conventionally and still has the energetic disturbance. And I think we need to think about that. If we think about it too long, it'll make us crazy, because we'll realize, how deeply ill the population is. But we also can see the differences in siblings and groups of animals, those animals who have had dynamic care, who have perhaps been exposed less to vaccinations, who have the benefit of eating species appropriate diets, who are in an environment where they're not as socially and otherwise stressed, where we can get some actual normal species usual behaviors and that sort of stuff. And in those families, we'll actually see individuals who are more vital and expressing that, that their level of disease in a I'm going to say more appropriate manner, or less detrimental manner. So I think it's really really significant when we talk about those sorts of things. So the implications of that, and this is kind of rhetorical, and I just want to say the words so that we can think about this. When we think about this, then, what are the implications about our choices in care? And I think a lot of times, especially the new homeopaths, and what we kind of get onto a lot of times is, we do this because conventional medicine is bad, or because there's some greater sense of, whatever. But I think that we need to get beyond that sort of right or wrong of that, and just really look at what are the energetic health implications in the care. What is the influence and the potential influence on the subsequent vitality of the individual, and then the potential vitality of the offspring? And I'm remiss, because I also didn't put in that whole question about when we treat in dynamic ways, we dynamically influence the whole family, the whole group, the whole hive, going back, looking at that swarm from Spikenard. And we see that in really well applied dynamic medicines. We'll see it in homeopathy, where you treat some members of the herd and the whole herd elevates. We see it in families when we treat that. We see it, I've seen it. I'm sure if Cindy's on the line, she can relate with this. Things like really well dynamically applied, really vital acupuncture stuff, R. Thorson stuff, where you can treat one individual and you see the 4 individuals who are sitting side by side. Every single one of them changes with that. So I think that we've really got some places to work in that in that larger dynamic. And it's always interesting to me that how an art and science that some people feel is so rigid and rule driven and anal retentive or whatever it's been described as to me over the years, that it actually has this huge deep potential for some really amazing holy moly stuff that is definitely not rigid and definitely is really dynamic. So then that question is, how does this family history influence our assessment for the individual that's actually presented in our care? And is that a place where we can get some early warning signals that maybe things are not running on all cylinders, or that we may need to seduce that response out of that animal? Yes, he's young. Yes, he has few symptoms. He might look superficially healthy, but if he's from the loin of that level of disease, we might be starting to think that maybe he's not doing these things because he's so healthy. Maybe he's not doing these things because he's actually so sick. I put these in there for those of you who never see cows and never see cows with health stripes on them. These beautiful big corduroy lines that we see on the side of cows when they're just running on all cylinders and doing really well. So one of the things that I look at too, and we look at or should look at as clinicians, is that herd history. And I'm not going to dwell on it, but we can also sometimes be tricked by herd history. Sometimes talks to us a lot about management and obstacles to cure and obstacles to clear expression of the case. It can show us that, as well as individual susceptibility, and we also can look at that individual susceptibility and start to talk about how we can have a variety of animals raised up in the same situation, but they may have different articulation of their disease or their imbalance based on that individual susceptibility. So why does one individual get turned upside down with changes in diet where another individual doesn't? And again, is that is that super sensitive stuff, or is that lack of resilience stuff? That's a sword, I think, that does cut both ways. We get lots of situations where some folks get, once you get exposed to a whole bunch of crappy food, for example, and you're just so used to feeling crappy, you forget what it's like to feel good. And then when you start feeling good and you know what that feels like, and it's like, oh my God, I can't believe I ate that, and I get really, I feel really bad from that. Weighing that against an individual who is so sensitive to changes in food that every time anything changes, they get turned upside down, or that they have to eat a really restrictive diet, or they get turned upside down, or a vaccination is enough to turn them upside down. Those kinds of things, it's not a black or white situation, but relatively healthy individuals should be able to have a beer and eat some Doritos and not be sick for not be sick for a month or a year or a week. So I want to talk a little bit about stuff, and we've talked about this throughout, that now we're looking at that individual history, not just the examination of the individual, but historically. Are there symptoms or are there no symptoms? And let's not get tricked by the fact that no symptoms is not necessarily, related to being vital. We looked at that pattern of disease, the stuff that I talked about before. The thing that I see a lot of times, it really seems to me difficult for students to wrap their heads around, and we tend to sometimes, depending on the kind of clinical practice that we have, we forget it's like a big quilt or a contra dance or flying across the country, where we're seeing patterns of stuff instead of individual moments of things. And so we've got this living, breathing, moving tapestry of stuff, and we forget to compare, how was it compared to last month, or how was it compared to 6 months ago, or how was it compared to however long ago. And that whole question that it's really served me well over the years is looking at that three-dimensional model. Where in the body is a symptom? What kind of symptom is it, and how did that pattern change over time? I don't care what you call the disease. I don't care what you call the diagnostic label. It's how does the body articulate that? Where is the articulation? Is it in the mental and emotional realm? I was always taught and sort of intuitively knew and finally was able to put words to it that the disease starts fundamentally as a rent in the spirit, and that rent in the spirit gets manifest in the mental and emotional and physical body. And if we're going to truly cure disease, we need to, because it starts in the dynamic rent in the spirit level, we have to treat at that level as well. The other thing that we look at that can give us clues about that vitality is, do we have the naturally occurring disease, or do we have the manipulated disease? And as we said earlier, does it make a difference? Um, was that easily manipulated? You did one little thing, and my gosh, the apple cart got totally upset, and things are just kind of coming undone right now, or did it, did it have some buffer, so it doesn't want to necessarily shift to non-dynamic, non-curative manipulation. One of the things that we often ask is that individual able to make a symptom, make a strong symptom, with clear modalities, and make its symptom known. This is a really great example that I just stuck in there to remind me about that. This is a young calf, made a strong symptom with clear modalities at a couple of days of age. This pooping episode is less than 24 hours old, so you can see how corrosive that is. This isn't a calf that scoured for ages and ages and ages. This was probably 18 hours, maybe past the first time it pooped loose. And so here's an animal that gave us really clear symptoms, gave us really clear modalities. Yes, we know it's got a pre-existing chronic disease. This is an animal that responded really nicely to the first prescription. And this is an animal that we know, because it has pre-existing chronic disease, that we're going to have to go back and treat her again after the mercurius diarrhea, seems to have been cured. We know that there's pre-existing disease under that. This is another talking about, is this a naturally occurring disease, or is this a manipulated disease? And this was an animal that came with a really not a great history, wasn't well nourished, didn't come from healthy parental stock, but had piled up on top of the pre-existing disease poor nourishment. It wasn't fed well as a baby, because its mama didn't know how to make very nutritious milk, and the humans that were involved didn't know very much about feeding animals. You can see he's got quite a bit of edema under the jaw from some parasite load, and he's also out in pasture that is really, really energy deficient. And those things will all set this guy up to present with a group of symptoms. But we need to recognize that both the vitality of this animal was being eroded by those errors, and also the way it tipped so easily among that whole group of other calves that did not have those backgrounds. And we ended up with this big messy, actually it happens to be a mercurius eye, that was treated really simply, actually. But the thing that makes that difference is knowing that we have to do that. To do that is not fair to say, to go back and correct the underlying things, as well as recognize the level of disease that this animal has, and recognize the relative fragility of this animal, lack of vitality of the animal, because it tipped really, really hard with a relatively small insult. So again, not to be tricked by the presence or absence of symptoms, recognizing the influence of diets and supplements. Are they so sick that they need a really rigid schedule They need really rigid ingredients. They don't have the ability to eat a wide variety of foods at different times, and that sort of stuff. The same with the relative susceptibility of the individual. Do they show some resilience? Can they go off schedule? Can they travel? Do they get exposed to, if there's parasite eggs? This is me who doesn't believe in the germ theory, but if they're exposed to a pathogen or contagion or something like that, do they have some resilience, or are they really brittle that everything is going to just set them off, that they're really in this tenuous balance, and the least little thing is just going to get their marble rolling. I think about brittle landscapes like that too, that are really sensitive to those kinds of things. So so when we look at that, we also look at the response to treatment. And we talked about this earlier, the fact that responding to treatment, sometimes the things that made us really puff up our chests and think that we were really good clinicians were actually some of those things where the body was saying, screw you, honey, like I am not particularly vital. I am really easily manipulated. I'm really wimpy. I'm really easily influenced. And you can give me 3 days worth of a 10-day antibiotic prescription and you have cured my quote bladder infection, and it's never going to come back again. And we used to get really proud as clinicians about those sorts of things, and the things that frustrated us as clinicians about, my God, I've given this animal 73 different kinds of whatever for its ear infection, and it still wants to have an ear infection. That tells us a lot about, or can tell us a lot about how relatively vital those guys are. And we look at that, how does that make us an assessment, both in the moment of treating things and also when we're looking historically, when we get these 12 feet of medical records and all of this sort of stuff, and how does that response to treatment have us saying, no, we've got a vital animal that's really knows where he's going to put his symptoms. He knows he's got a stubbornness about what he's going to do. He's not so easily swayed. He's not so easily manipulated. Those sorts of things. That also, how does that help us prognosticate? What might we be thinking about in a case like that? What might we be thinking about in a case that had skin, ears, bladder, stiffness, something else, then something really scary? How is that going to help us have meaningful conversations with our clients about what to expect, how to treat, how to be brave in the face of stuff that they thought was cured, that sort of stuff. And I think one of the really amazing things is do we expect to see changes in vitality over the course of time, and if that is true indeed, on what does that depend? And when we see that happening, and we start seeing that increase in buffer and that increase, I often phrase it sort of in the apology that the individual has for the humans crashing around and doing silly things like goofy diet stuff or weird behavior stuff or non-curative interventions and that sort of stuff. The relatively more vital those individuals are, the more apologetic they are for those kinds of errors and crashing and trashing around. And I think that that when we see that happening over periods of time, I think it's real, it's changeable. I'm thinking back to the kitty at the beginning. There's a philosophy that we only have got this much energy, this much chi in our bucket. It was given to us when we passed through the portals, and that's how many we've got. And the question is can we increase it beyond that, I don't know the final answer to that, but I certainly know that we can do things that don't burn it up as fast, and I do know that we can do things that can, can enhance the vitality of stuff. And to me, that's where that's really powerful. One of the things that I see so often in reports from clinicians and students is, the vital or there was an enhanced sense of well-being. And my question is how do you know that? How did it show that? How is it, was it truly an enhanced sense of well-being from that really deep fundamental gut place, or were they just feeling better because they don't have a headache anymore, or they quit puking, or they're not itching as much, or whatever. And I think there's an that quote enhanced sense of well-being response really gets thrown around quite generously sometimes, and I would challenge us all to really look at the difference between somebody who's just not as overtly suffering as much, or not as overtly symptomatic as much, as something that's actually really feeling much better, and starting to be more interactive, starting to play, starting to be to have some chi circulating, and some movement happening, and that sort of thing. And I think if we were to be critical with that yardstick, I think that there's a lot of times that term gets thrown around without a lot of substantiation. Now, having said that, I also well know that a lot of times that we do see cases that we know that they're better. We know there's, it's the look in their eye, doc, like their whole presence changes, the look in their eye changes, their facial expression may change, become less strained, more relaxed, those sorts of things. And that may not have a 15-point laundry list that I can tell you this, and this, and this happening. But we also, I don't mean to say that we need to underestimate the value of that sort of enhanced sense of well-being, but I do think that gets to be a pretty rote response to hopefulness of reaction to remedy. Anyway, so that's mostly all of the things that I had in my kind of list of things to talk about. I'm sure I've skipped some stuff. I'm sure there's a great wealth of knowledge among the colleagues that are gathered here. I do know that over the years, talking to students and talking to folks who are doing presentations and certifications and that sort of stuff, that it's one of the frustrations that gets shared a lot is not being able to really be articulate about or accurate about making some sort of a judgment about that. And so that's why we decided that we were going to put this little bit of presentation together. I'm happy, Jeff, to open the floor to any questions or comments or anything, and we can just go from there.
Yep, I'm trying to unmute everybody right now, and
I think I can see questions if we need to, or
okay, great.
people can either raise their hands or type in questions or shout out. Or
yep, looks like Henry has his hand raised. I don't know if Henry, are you there? Can you speak? Did you have a question? Can you either say it or type it, or not?
And I think Judy's here too, right?
Yeah.
Judy and Stephanie, and I know that I know they spend a fair bit of time and energy on this, and I don't know if they had anything that they particularly wanted to add. Henrietta is probably there as well.
Yep. Stephanie?
Yeah, I thought it was excellent. You're so thorough, and I can't add anything. It's beautiful. Thank you.
Yeah, that, well,
I wasn't setting you up for that.
Yep. Anyone have anything they want to ask or add? Christina said that great job, Sue, and I agree. It was awesome. You covered like everything, and also true. But I do have a question. While we wait for other questions, actually, I have a couple, but and that is the vitality in food. So you said you don't really think, or you're not sure that the food that our patients eat
Oh no, I
can.
think it makes a huge difference.
Oh, you do. Okay.
I think it makes a huge difference. But I do think that some of the less vital animals are not able to handle some kinds of foods. I think you know, I related a lot, for example, to traditional Chinese medicine. Sometimes, you know, if we've got animals with weak spleen qi or spleen damp or those kinds of things, they're not going to be able to do a raw food very well, or a cold food very well. You know, we know that spleens digest the food in traditional Chinese medicine, and we know they want to be warm, and we know they want to be dry, and we know when spleens are cold and damp, they're not happy and they don't do a very good job. And so to feed them salad or raw cold stuff is not a great thing. And so I think that there's a lot of situations where we have symptoms that are artificially called symptoms of chronic disease that are actually errors in diet and stuff. I think that we can elevate vitality, and also the animal's ability to create symptoms by appropriate food. But I see a lot of situations where people say, I cured him with food, forgetting that we've also got pre-existing chronic disease there. Or if we get off the cure food, then things fall apart. And I'm thinking not necessarily getting off of real food back to commercial food, but I'm thinking of, restrictive commercial or restrictive diets. The old lamb and rice stuff that's mostly passe now, or that I have to feed this specific thing or else. And I think that the relatively more healthy we are, the relatively less rigid we are about those things.
Hey.
And I just want to say that there's sometimes such a complex interweaving of environmental disease and miasmatic disease. It's not always clear, where one begins and another ends. And also that, with the increasing environmental burden, toxic burden, I think that can push you into miasmatic disease too. So it's not a simple thing. It's
I
very
agree.
complicated.
I absolutely agree. And I think that in the same way that we see disease moving through the the sensation to the function to the mild pathology to the greater pathology, I think that those environmental influences can actually create genetic change through the generations as that disease deepens. And I also think that we can work the other way, that we can take genetic change and have it maybe it says that in the genes, but it's functioning in a different way. So yeah, I don't think there's neat tidy edges at all, for sure, Stephanie.
And we would have information now through the study on epigenetics, how toxins and foods can influence the gene expression and how that can actually be reversed.
Absolutely. Yeah.
And Christina had a question.
Thanks, Sue. Great job. One of the things that over the decades, so often homeopathic veterinarians complain to me about people not understanding everything that you've talked about today, Sue, and thinking, like you said, that the diet is because they're on a great diet, quote, great diet, because they're not vaccinating, then their animals should be healthy, and then being very upset when their animals aren't healthy. And it just underscores so much our need. We forget, I think, way too much that people are exposed on a daily basis to the opposite of what we're saying here today. And therefore, we need on a regular basis, on a much more frequent basis than we think, we need to be reminding people of all these facts. You know, whether it's a weekly email, there are multiple ways to do it, but people need to have that constant handholding. So I think that's a very important thing is to remember is all these everything you talked about, Sue. Just we need to be teaching this to our clients.
Well, and the thing that I find so interesting, and it's kind of up this last little while too, is, you know, how do we function like that, but actually have people not people it's really easy for people to function in fear and in sickness, and oh, if I don't do this, this happens, and oh, I've got this sick thing and I have to nurse it, and all of that sort of stuff. So I don't disagree with what you're saying, but we have to, in my opinion, phrase that more as a holy moly, bodies are amazing and look at what they can do, as a if you don't instead of a, if you don't do this, this bad thing's going to happen. And so look at these really beautiful, amazing, resilient, adaptable, creative bodies, and how can we, knowing what we know from our perspective as homeopaths about dynamic intervention to allow rebalancing of bodies, and to allow restoration of health. If we talk about it that way, that allows people to have a relationship with true deep-seated dynamic wellness, not the if you don't do this, this bad thing's going to happen.
Mhm.
And that to me is always, you know, I don't want to be a fear monger, and I know that as a clinician, and I know that when, you know, when we're teaching and being really picky, you know, we spend a lot of time picking on those things, but I really fundamentally believe that bodies are holy moly amazing, and they've got this incredible resilient capacity to respond, and that makes it even more important that we do dynamic intervention stuff, not non-curative manipulative stuff.
Awesome. So, conversely, Sue, how do you talk to clients about their easily suppressed or easily palliated animals? How do you explain to somebody that it may not be a good thing that 3 days of antibiotics resolved all the symptoms?
I know what served me well over the years, as far as, you know, making analogies with people about you know, about not knowing whether to take out the trash, do the laundry, do the ironing, or wash the dishes. You know, your house is in really disorder there, and I talk to people about just stubbornness, about how it can be a relatively positive thing to have bodies want to make symptoms and be stubborn about what the symptoms are. And that, you know, we spend a lot of time talking about how it is relatively healthier to have a symptom on the outside, even though it smells bad, looks bad, you can see it, and you're really scared. We talked about this a couple of weeks ago, or a couple months ago, um, about how we have clients that are more upset if their dog comes in with ear discharge or a skin lesion than they are if they've got a grade 97 heart murmur and they're in end stage renal failure, because you can see that stuff. You know, and so we talk a lot about the need for having good structural stuff. You know, I'd rather have a well-made couch with ratty upholstery than a couch that's falling down but has nice upholstery, you know. And those sorts of analogies seem to have worked over the years. I don't know.
Okay, thanks. Any other comments or questions?
How good, just a yes or no, or a hands up or hands down? I mean, I can't think that I know most of the people on the call, and I would imagine that we've gotten better over the years with that assessment. Is that fair to say?
Yeah.
I think with the people, with people who have been, have some time under their belt, I think the people that are having trouble are more the new graduates, the ones without the experience. Um, I think most of us through trial and error, success and failure, learn how to communicate better with our clients. And we know that one shoe doesn't fit everybody, that we, some people we have to hold their hands because that skin lesion is driving them crazy, but yet you got someone else who totally gets this whole idea. But I think the newer students, at least from our experience in certification, the evaluation of the vital force is one of the things that we pull our hair out trying to convince them that this is really important. And it begins with a good history, and they're clueless. And I know that at our very first AVH conference in San Antonio 100 years ago, I was on a panel, and people were slamming conventional medicine left and right. And one thing that I had pointed out then, and I still remember when I was in vet school, which was 100 years ago, we were taught you took a thorough history,
Mm-hmm.
a really complete history. Then you do a really complete physical. Then you put together your problem list. And then you figure out what you're going to do after that. So how much different is that from what we're doing as a homeopath? It takes us back to you really need a good history. You really need to assess what's going on in the pet and the communication to the client. I mean, it's not throwing the baby out with the bathwater when you get out of vet school and you switch to homeopathy. It is the same underpinnings. We just use different medicine
It's a different
to,
medicine. Yeah.
yeah, it's the same process. It's still practicing the art of medicine, but we have different potions.
Mm.
Yeah, and I think one of the things that it cracks my heart, actually. It it cracks my heart to see people really struggle with homeopathy. Not that it's not a thing that one struggles with. I mean, it takes a significant amount of rewiring and work and attention and honing and stuff. But one of the things that I see happening clinically with some of my colleagues is because they don't have an understanding of this subject, because they can't make the assessment of the vitality of the individual and where the vital force is, and where the disease is in the pattern of diseaseness, then their therapeutic interventions don't match what that individual needs. And so there's oftentimes a lot more upheaval and drama and excitement and frustration and late office calls and, oh my God, they're off to the emergency clinic or whatever. And that in of itself makes that transition to being a homeopath and to being comfortable in the art and science, and to us fulfilling our highest calling, that gentle, smooth, amelioration of disease. And it just, it's I don't even have the words, obviously, to say this. You know, it's like this strange emotion. It's, you know, frustration and disappointment and compassion and whatever, you know. And you just think, oh man, if we could just somehow get folks to understand, to be able to wrap their heads around this, it would help smooth a path that isn't always necessarily smooth.
But I think the part of the problem too is the lack of the practitioner having a smooth, complete understanding of what they're looking at.
I agree.
Because if you can't, you know, from what we see, I keep going back to certification because that's my window into what's going on. And with the newbies or the people coming in, we ask them to explain, you know, the progression of disease. They leave it off. We ask them to explain the vitality of the vital force. They dance around it. And they dance and they dance and they almost hit on it. It's almost like they're afraid to commit. They don't realize that nothing's cast in stone, that you can say, okay, I feel that this, you know, puppy has a strong vital force. And of course we're reading like, holy shit. And but that's our teaching moment.
And that's okay. That's okay.
And
If that's your
okay
clinical
because
impression,
right.
But then you do something and the puppy plays his cards back and you go, holy shit, that was not what I expected. Then what we do is say, man, I really, you know, I really didn't assess that as accurately as I might have.
Right, and that's where certification guides these people. We ask them the questions. Some of them don't like the fact that we think they're wonderful and perfect. But we do, you know, we ask them, well, what happened at the follow-up? You noticed blah, blah, blah. What's going on with the vital
What does
force?
that mean?
You know, what happened? What does it mean? Is it really, you know, well, in the history, everything is suppression. Well, you're right. It's not always suppression. Even with prednisone, it isn't always suppression. And but yet you can see progression of disease or something, and they don't get the value of figuring out what is the progression of disease. When did these things happen? And I have the hardest time of people getting their history. And they go, well, you know, I didn't want to talk to my vet, blah, blah, blah. I said, I need the history. And sure enough, I'll find out like blaringly there was a vaccine and a month later the animal seizured or something. You know, you see something, or they changed the diet and or gave some medication or something, and then something happened. And it's like, oh, okay. So we know this is an issue. And it helps you. And when they say, well, we only look at the symptoms, and that is actually a criticism I've heard from a veterinarian who actually the only studying he did was Christina's course. And he said, well, homeopathy only treats the symptoms. It doesn't get to deal with it doesn't deal with the disease. And I mean, okay, you know, and how often do we say, oh, well, you know, what's important is the symptoms, and that's what the newbies are. They're focused on the symptoms, but they forget everything else.
Well, and yeah, and there's, you know, there's not I'm well known for saying, you know, I don't get a sense that there's a dog attached to any of this, you know, and yeah, it's pattern. It's a pattern recognition. It's, you know, here's the pattern. This is what happened. Yeah.
Right.
Sue, I really appreciate, can you hear me?
Yep.
I really appreciate this little talk. It's been good for me to think about again, because thinking about it as you talk, I realized that I'm kind of, I guess because I've been at it for so long, I don't even think consciously about assessing the vital force, but I'm doing it.
Right.
It's like I'm just thinking about a few cases that I've even had this week that were so different just based on their vitality. And it's just good to keep that in mind.
Yeah, and I think that's a good reminder, because then somebody asks you about how do you do it, and you think, oh man, how do you
Yeah,
ride a
well,
bicycle,
yeah,
or
and I know how to do it. And it's the ways that you said. And then talking to one of the things, of course, I've had a lot of the same experiences that other people have said. And one of the things that comes up because I'm explaining to people that their pet needs to be on a good plane of nutrition in order to heal, and they can't really heal with just that, but they can't respond to the remedy without the nutrition. So so sometimes they'll say, well, he's been eating Purina for 7 years, his whole life, and it's been fine. And I just tell them, yes, that's in spite of it, not because of it. So, and then they seem to understand that, it's a nice, strong, vital dog that can eat Purina and still seem just fine and be just fine for a number of years, and then they just can't anymore.
right, right. That was like Henrietta's analogy. You only have so much concentration, and and I use the analogy to clients, and to horse racing people too. They've got this much toothpaste in the tube. They can either use it all today, or they can use it over a period of time.
Right.
Yeah. Yeah. Yeah, it's interesting, and it's I don't underestimate ever the power of nutrition. The challenge that I have in communicating that, though, is that is a large faction of folks who think that that's the only thing, and it distresses me to see folks struggle nutritionally trying to get stuff. Stephanie's point totally aside, because of the really strong medicinal influence and other things that are happening, but we see people struggling and struggling and struggling with nutritional stuff when really they need dynamic chronic disease treatment, not another nutritional tweak.
Yeah.
So in that same vein, Sue, aside from nutrition, 'cause you said, that does help articulate symptoms, it does help the vitality in some individuals. What other vitality building methods, because we certainly know lots of ways to step vitality, but what are other vitality building methods that you use or recommend for people? If any.
I think there's a lot of things, but I think the fundamental stuff is that that difficult to explain thing about relationship and safe space and family, herd, flock, pound, kennel, whatever dynamics, and how some of the stuff that animal owners do, thinking that they're being good, kind, fair, loving, rescuing, whatever that laundry list of things are, sometimes are very difficult on animals. And whether it's the job that they have, or whether it's the fact that they were rescued and taken away from kind of their only useful life that they knew, and just those things. I mean, that stuff, I think that family dynamic stuff can be really corrosive and erosive. I think that there's some technique stuff that is you know vitality building and not manipulating. A lot of those techniques depend on who's doing the techniques. But I really look a lot at what's dynamic and and yes, everything's dynamic because we all have energy, and so but when we really talk about dynamic intervention stuff, so and how those things can be applied in curative ways, and how those things can be applied in non-curative ways, in manipulative, non-curative manipulation, whatever we're going to use for that term.
Hmm.
Yeah.
Okay. Anyone else? Any other questions, comments? Anything?
I think,
Nope.
we got to just, it's really hard to trust bodies, and, and, and one of the things that I find, and it may just be a phase that people are going through right now, is it doesn't seem like folks trust their clients, or they do trust them, you know, and, and, and I think that we need to understand, I talked to some of my colleagues about this recently, and we need to understand that part of our work is actually getting and allowing the client to tell the animal's story, and that it doesn't necessarily need a third party intervention person. Yes, medical records are helpful and useful, but the case is usually not gotten out of the medical records. The case is usually gotten out of the anamnesis and the observation. And 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 I see a great deal of not trusting clients, and that distresses me. And I mean, I know that some clients are really difficult, and I know that it's hard to manage them, and you just want to, like, push them off the cliff or in the ditch or whatever. But I think, Judy's earlier point about getting that good history, and yeah, part of it is talking to the vet, but really part of it is creating a situation where the client is able to do the remembering and is able to tell the story and is able to be comfortable and confident that they're in a safe space with me as the clinician, that they can, I don't care what they say. I'm gonna get clear on the information, but I'm not gonna think they're stupid or smart or be judgy or whatever. These guys are the best eyes and ears and voice that these animals have, and and it's our responsibility to let those clients do that job. you know.
But I want to clarify the thing about the history. I can tell you that 90% of the time, if I don't have the history and I get it later, and then I talk to the client, there's half the history they forgot. Well, what about that earache at
That-
8 weeks? And they're like, oh, what ache? What earache? And
yeah.
I said, well, tell me about it. You got the puppy, at 7.5 weeks. Yeah. Okay. What happened when you went to the vet? And then someone says, oh, yeah, that's
Yeah.
right. He was shaking his head. Well, what else was going on with
Yeah.
there? It also cried. Oh, okay. Why don't you tell me this story?
Yeah.
And and then they're like, they laugh, some of them, and it's like, well, I guess I didn't remember
Well,
everything.
and the thing that they can give you by talking to the person is they can give you the not common diagnostic label, but they can give you the unique presentation. I mean, what was that individual doing that got the doc to write down whatever? The other thing that I found, Judy, that's really helped me over the years case taking is I always let the people tell the story. I clarify points and stuff, not usually while they're telling me the story, very rarely, very rarely. But what I do, be not the very last thing that I do, but in the latter part of the case taking, is I actually do a physical exam from nose to tail with the line of questioning is, do they now or have they ever? And literally, just exactly the way that you would go, nose, eyes, ears, vision, teeth, drooling, movements of the tongue, holding the tongue, swallowing, coughing, and a lot of times that will
Yeah.
remind people of stuff that they've forgotten, and it's literally, and I just keep reminding them, do they now or have they ever?
Right, that's really true because I do the same thing. Someone comes in brand new, has no clue what homeopathy is, And they start spouting off all these diagnoses that they've been told and everything. And I said, okay, that's fine, but let's talk about the story. Tell me about it. So, you know, what's different about your pet versus the diagnosis? And it gets them thinking. And then I always save my exam for the end, because I want them to go through. And usually what I do in my history is that if I have questions, I'll leave a blank line underneath. Anything that is characteristic or like a modality or something, I underline so I don't lose it in the history.
Right. Yeah. Yeah.
And then I'll go back and ask, and this is something that I've seen Andre do for like several years now. But I'll go back and ask them again what was going on at that period of time.
Yeah.
You know, what happened? What do you remember? What did it look like?
What do you mean? Yeah.
Yeah, what do you mean? Can you explain it to me? I said, I'm trying to picture it.
How did they show that? How did
Right.
they show that? What was
Right.
going on in the house? You know, what
Right.
time of year was it?
Exactly. Did you
But it-
sleep
but-
the night?
And asking those open-ended things can be really helpful. And then we need to get, you know, also really specific. Well, what do you mean that there's blood in the poop? You know, is it?
Yep. And now we're getting into the case taking webinar.
Yeah, it's exactly. It's a great segue. Let's do it.
Yes. All right. So we'll do it right now. No.
Yeah.
All right.
Yeah.
Any other vitality questions, anyone? Vitality comments? Nope. Okay, Judy, Stephanie, Henrietta, anything from you guys? All right. Well, I just would say thank you, Sue. That was awesome. And we really, really appreciate it. And thank you all for coming, for sharing your time with us. And we'll see you next month, unless you want to say, Sue, anything to say to end.
On the 10th, right? Next
I
month.
believe so. Yep.
Yep. No, thanks very much for your kind attention, guys.
See you next month.
Thanks, guys.
All right. Thank you all.
Thank you.
Bye.